Good evening, everyone. Welcome to the BTOG Stage 3 Non-Small Cell Masterclass. Thank you very much for joining us. I'm delighted to welcome you to this meeting and also to my three esteemed experts, Professor Corinne Favour-Finn, Professor Samreen Ahmed, and Dr. Alistair Greystoke, and we're going to be discussing Stage 3 lung cancer. So moving on to our next slide, which is going to magically move, I hope. There we go. We need to thank our platinum sponsor, which is Amgen. As you know, these webinars, we're grateful for support of our industry partners, so thank you to Amgen for supporting this. If you'd like any information about BTOG, please contact Dawn or Gina. You've got the email address there and you've got the web page there. If you're not a BTOG member, then shame on you. Why not? You should be joining up. It's a wonderful thing. And you can find details on the website there. If we could move on to the next one. So just a little bit of housekeeping for those of you who may or may not have done these webinars before with BTOG. We are trialing polling questions, and you can also send in questions as well through your portal. So the trick is, if you've got your portal open on full screen, you won't be able to see the questions and answer section. So don't make it full screen, reduce it, and as if by magic, the Q&A bit will open up. We will send you an email, and you can give feedback for that. And if you do that, you then get your certificate of attendance. And this is registered by the RCP as a CPD event, which is all very exciting. So moving on to the agenda. So here is the exciting agenda we have in front of us for the next hour. We're going to kick off with Corinne talking about chemoradiotherapy and consolidation immunotherapy. Samreen's then going to take the baton and talk about perioperative immunotherapy. And then Ali is on the home straight for novel agents. And you'll be looking at thinking, but hang on. We're talking about stage 3 non-small cell lung cancer, and you haven't mentioned the word surgery. Now, that is not to diminish the extremely important part of surgery has in stage 3 lung cancer. But what we found with these webinars is an hour's about right. Much more than that, and we all struggle a bit, and we want to go off and get our supper ready and so on. So we're trying to keep within an hour, and we felt if you try to do everything, we would probably rush it a bit. So we're going to focus on these areas, and you're going to keep your eyes peeled for future events when we will, of course, bring in the surgical aspect for that. And I'm very much hoping we have some of our surgical colleagues online who will be asking questions through the Q&A. So again, let's focus on those questions and answers. So I'm going to stop prattling on. I'm going to pass over to Corinne. So those of you who don't know, Corinne is a professor of thoracic radiation oncology at the University of Manchester and also a consultant clinical oncologist at the Christie. Corinne, over to you.
Thank you very much, Tom, and good evening, everyone. So I'm delighted to talk on chemoradiotherapy and consolidation immunotherapy. So these are my conflicts of interests. So, as you will know, the majority of our patients with stage 3 non-small cell lung cancer are not suitable for surgery, either because they have multiple comorbidities or because they are not resectable. And the standard of care is chemoradiotherapy, aiming to achieve both local control, but at the same time reducing as much as possible the side effects. With this treatment, we have, however, two problems. One is the risk of local relapse. Approximately a third of the patients will relapse locally at 2 years, and also metastatic relapse. So this slide summarizes the current standard of care in this disease. So for fit patients, it is concurrent chemoradiotherapy. And we have learned over the last few years that there is no role for dose escalation using conventional fractionation. The standard dose fractionation of 60 gray in 30 fractions was established by the pivotal RTOG 0617 trial. This study and others has also highlighted the role of intensity-modulated radiotherapy, which allows the radical treatment of patients who were deemed previously only suitable for palliative treatment. With regards to systemic treatment, we deliver cisplatin-based chemotherapy with radiotherapy. We have learned from a number of randomized controlled trials and meta-analysis that there is no role for either induction or consolidation chemotherapy. And to date, in stage 3 disease, there is no defined role for targeted agents, including in patients who have targeted mutations in the context of chemoradiotherapy. So in summary, to date, unfortunately, this is very different to what's happening in the stage 4 setting. We have no individualization of radiotherapy or systemic therapy. So the standard of care treatment is concurrent chemoradiotherapy, but is that delivered in the routine setting? And many of you would be aware of this national audit that was published last year. And what we've learned from this important audit is that in both stage 3A and 3B, the majority of patients in the UK receive either palliative treatment or best supportive care. And if we look at patients who are treated with radical radiotherapy, only 2/3 receive chemotherapy in addition to radiotherapy. And within the patients group treated with chemotherapy and radiotherapy, only 1/3 receive concurrent chemoradiotherapy. So for me, these are pretty shocking figures because in summary, less than 5% of patients with stage 3 disease in the UK are treated with the best standard of care of concurrent chemoradiotherapy. Now, we had some good news in 2017 and 2018 with this IO tsunami, so the publication of the Pacific trial. And just a reminder, many of you will be very familiar with this design, but just a reminder that the patients included in Pacific were patients with unresectable stage 3 disease who had not progressed after at least 2 cycles of chemotherapy given concurrently with radiotherapy. There were PS01 patients who had side effects that had resolved. This was an all-comers population, so tissue was not mandated. And the patients were randomized 2-to-1 between durvalumab and placebo for 1 year. There were 2 co-primary endpoints, PFS and overall survival. This slide is just to highlight that the Pacific population is quite a selected population. So less than half of the patients were aged above 65 years, and in the UK, the median age of lung cancer is 71, and almost half the patients were PS0. I don't know how many PS0 you do see in your clinics, but certainly in Manchester, I don't see very many of these. Now, what was quite reassuring with Pacific was the safety and the toxicity profile. So no major difference between the 2 arms. And what reassured us, particularly the clinical oncologist, was the risk of grade 3/4 pneumonitis, which was less than 5% in both arms. I had the pleasure of presenting at ESMO this year the updated analysis of survival and PFS at 4 years. And for the first time, the median survival was reached, and it's an unprecedented 47.5 months in the durvalumab arm. There was a reduction in the risk of death of 29%, and the 4-year survival is almost 50% in the durvalumab group compared to 36% in the placebo group. There was also a sustained benefit with regards to PFS, with a reduction in the risk of progression of death of 45%. And then similarly to what had been presented previously, there was consistent benefit in favor of durvalumab in most subgroups, at the exception of patients with EGFR mutations, but this was a very small subgroup of only 43 patients, and also, as you will know, patients with PD-L1 status of less than 1%. So in the UK and in Europe, durvalumab was approved only in PD-L1 more than 1%. If you're interested to read more about the debate around whether patients with PD-L1 of less than 1% should be treated with durvalumab, I would point you to this paper, which I do not have time to discuss today. Now, some comments on Pacific. So as I said previously, is the Pacific population really representative? And we'll talk a little bit more about that in the next few slides. Unfortunately, in Pacific, there was no data collected on disease volume, dose to organs at risks, and radiotherapy techniques. So therefore, it is difficult to know whether we can extrapolate the data from Pacific to an all-comers population. And for example, as you can see on the right-hand side, patients with large volume disease. We clearly do not have an ideal biomarker as yet. Certainly, PD-L1 has limitations. And there are quite a number of uncertainties still based on the data that was presented. So we have quite a number of outstanding questions, for example, on the safety of treating patients with large volume disease, the optimal radiotherapy dose and fractionation, as most patients in Pacific receive a conventional dose of around 60 gray in 30 fractions. We have questions about the tolerance of durvalumab in the elderly, but also in patients treated sequentially. And to address that, we have a Pacific 6 trial that is currently recruiting in the UK very well and will be completing recruitment internationally in January. There are questions around the timing of chemotherapy and radiotherapy and durvalumab, and whether durvalumab can also be delivered concurrently with radiotherapy, and that has been addressed in the Pacific 2 study that is completed and will be reporting, I think, in 2021 or early 2022. And then finally, there are questions around the optimal duration of durvalumab treatment, which was 12 months in Pacific, but should it be less, should it be more? We don't really know. Now, beyond Pacific, of course, there are also a number of outstanding questions, again, around the optimal radiotherapy dose, schedule, and volume of disease. The questions around the type of immunotherapy that should be used in combination with radiotherapy, so CTLA-4 and other drugs. Is it safe to deliver immunotherapy concurrently with chemoradiotherapy? And there are many international trials ongoing addressing this question. And then finally, the Holy Grail: who are the patients most likely to benefit from consolidation immunotherapy post-chemoradiotherapy? And if you're interested in that question, there's some excellent papers from a Max Dean lab in Stanford on ctDNA, and they do suggest that the use of ctDNA could be used to identify these patients who would benefit. So these are my conclusions for the first part of this talk on chemoradiotherapy and immunotherapy. So concurrent chemorads followed by durvalumab is the standard of care in good performance status patients who have responded to treatment and recovered from side effects. But that is a treatment that is not available if PD-L1 is less than 1%, certainly not in the UK, but also should not be considered as yet, pending further data, if a definitive treatment is not concurrent treatment, for example, in the sequential setting. There are trials ongoing with other immunotherapy agents, and some of them will be reporting within the next few years. We have quite a large number of unanswered questions, particularly regarding the optimal chemoradiotherapy consolidation and selection of patients. And then importantly, we need to include patients in clinical trials and also increase the proportion of patients treated with concurrent chemoradiotherapy in the UK. Now, when we were preparing this webinar, Sanjay asked me to cover results of a lung-out trial, which was presented at ESMO this year. So lung-out is a study that was funded in the UK by Cancer Research UK, and many thanks to the centres that included patients in this important study. So this is a study in completely resected non-small cell lung cancer with N2 disease, who were then randomized between radiotherapy postoperatively and no radiotherapy. So you can see the characteristics of a patient. So majority adenocarcinoma, majority had chemotherapy either pre-op or post-op, and more than 90% of the patients had a pre-treatment PET scan. Just over 50% of the patients had more than 2 stations involved within the mediastinum. Primary endpoint was disease-free survival, and as you can see from the graph on the left-hand side, no significant difference between the two groups. But I would like to point out that the 3-year disease-free survival was actually slightly higher in the port arm, not significant, but 47% versus 43%. The mediastinal relapse rate was reduced by port, and as you can see from the table on the left-hand side, there's a high risk of mediastinal relapse, almost 50%, if patients do not receive post-op therapy. And in terms of, you can see from the graph on the bottom right, significant difference in survival. Now, what's really important is to consider the cause of death, and particularly there was more risk of dying due to progression of recurrence in the control arm. But I'd like to point out that there was more cardiopulmonary toxicity in the port arm, and that's really important. We now have more and more data in the field of lung cancer showing that radiotherapy, well, dose to the heart matters and actually can be associated with further deaths. And that's what this study has also demonstrated. As you can see on the table on the right-hand side, 10% of patients, or 11% of patients had at least one late cardiac or pulmonary toxicity compared to 5% in the control arm. So the main conclusion of this study is that conformal port cannot be recommended as a standard of care in completely resected stage 3A and 2 non-small cell lung cancer patients. However, we have to consider that the mediastinal relapse is high without port, around 50%, and there's a need for post-op surveillance. There is no role for port after complete resection in the routine setting, but perhaps at the exception of patients with extracapsular extension, and these patients were actually excluded from lung out. There was an excellent survival result reported in the control arm in this study. And therefore, this eternal debate between chemoradiotherapy versus surgery, in my view, is still very much alive and will continue for years to come. And then finally, the role of IO in the surgical setting is an important question. So just to finish on the note of the eternal debate of surgery versus a non-surgical approach, in the stage 3 setting, the Pioneer study led by Matt Evison and Janelle York in Manchester has just started recruitment, and we recruited the first patient this week in Manchester. This study, which is a feasibility study, compares a surgical to a non-surgical approach, and we're looking at the acceptability of conducting a phase 3 randomized controlled trials with quality of life as a primary endpoint. So very important study. Now, I'm getting to my polling questions. So the first one that I would like to ask is there a role for surgery in stage 3 non-small cell lung cancer in the immunotherapy era? So that's a very simple yes or no question. So I think you all have to vote on Slido at this stage. And then there's a second question about the role of port, and you can tick all of that apply. Is there a role of port in patients with completely resected N2 disease, in patients with extracapsular extension, in patients with R1 resection, so incomplete microscopic resection, or none of the above? So I think if you all vote, and then Tom will pick up on your answers, and then that's my final message. Thank you very much for listening.
Corinne, thank you very much. Who better to go through the important role of radiotherapy than Corinne? So doing our interactive polls is a bit of a new thing for us, and we are aware there's quite a lag between Corinne showing the slide on her side and it coming through to you guys. It takes about 30 seconds. So I'm hoping that you've had a chance to go through them. We are a little short of time, and I'm now going to see if I can go through the results. So hopefully you can see the results to Corinne's first question. is there a role for surgery in the stage 3 disease? So 90% say yes, and 10% say no. So we are a group who appear to, by and large, appreciate that. And for the, is there a role of post-operative radiotherapy? So hopefully that might be popping up. I'm hoping you can see that on your Slido. So there we go. Patients with R1 resections are the ones, and those with extracapsular extension. And in fact, that's really handy, guys. You are reading my mind, because one of the questions that come through, Corinne, if I may, just for 1 or 2 minutes, is there anyone who would be suitable for radiotherapy post-operatively? And I guess that extracapsular R1 group of patients, what would your personal or your MDT's opinion be on those kind of patients? Does lung art tell us not to do it, or has it just not quite answered that question?
Yeah, no, it doesn't. So as I said, lung art did exclude patients with extracapsular extension, and they are patients, as we know, who are at higher risk of local regional relapse. So I think, we should definitely discuss potentially to give port. However, I think, one of the really important message for me is this issue of cardiopulmonary toxicity. And, perhaps we should personalize a bit more our decisions. So, for example, if we have someone who has extracapillary extension, we're considering radiotherapy and the dose to the heart is particularly high, someone with cardiac comorbidities, then perhaps we should advise them that they are high risks with regards to long-term cardiac problems.
Thank you. One other question, just the last one I think we'll do, because we are a bit short of time, which is what we always say in these things. Let's say you've got someone in the in your MDT, you are looking at your outcomes over the previous years, like indeed we do, and we find out the MDT is under-delivering on our concomitant chemoradiotherapy. We're not doing it enough, even for the good performance status patients. It's clearly a UK thing. Individually, what can we do? What should we do in our MDTs? How do we make this better, practically speaking, on the ground? What can our colleagues on the end of the line do to make it better?
Well, that is a really important and very complex question, Tom. So in my mind, there are various issues, but the two main issues is one, availability of technology, and certainly since we've had IMRT and VMAT available in our center now, for quite a long time, we have been able to treat many more patients radically, but also with concurrent chemorads. That's one aspect. Another very important aspect is the training. There are typically centers where people have been trained in a very, very conservative way, and many of the registrars in the UK do not tend to move from one center to another and then continue working in that conservative way. So I think actually BTOG could have a very, very important role in that, in the raising awareness and perhaps developing workshops that would be very much focused on how you select patients for concurrent chemorads.
Thank you very much. And it's certainly something in our MDT that one of my MDTs where we need to try to build that. And I'd also encourage people to complete their National Lung Cancer Audit returns, because if you can demonstrate how your MDT is performing, data is quite a good way to try to change behaviour. Corinne, thank you very much. That was magnificent. We're going to move down the road to Leicester with Samarine Ahmed, who is a consultant medical oncologist, and Samarine is going to talk to us about perioperative immune checkpoint inhibitors. A lot of data has come out over the past year and a half about this, and Samarine, thank you very much for taking us through it.
Thanks, Tom, for inviting me. So we'll move straight on. So actually, there's more questions than answers, I would say. Outcomes of systemic therapy administered in this role given neoadjuvantly, is it the same as giving adjuvantly? And I'll show you a little bit of data around that. Is immune checkpoint inhibitor blockade safe preoperatively? And I'll show you a little bit data around that, and we can have a discussion about that. The third question I pose is that neoadjuvant checkpoint inhibitor blockade, given long, is it providing us with longer term immunogenicity, i.e. resistance against relapse? And that's really the golden nugget that we're all after. And then, does pathological complete response have prognostic value in non-small cell lung cancer, as it does perhaps in breast cancer? And we'll maybe just amble over the evidence regarding that. Okay, so why is surgery not enough? You've heard this from Corinne already, but this is really what focuses your mind on the survival of non-small cell lung cancer in the stages. When you've got larger tumors which are node positive, your 5-year survival rates are falling well below what you would expect, and we're going down to 60% with larger tumors, and then by the time we've got node positivity, we're down in the 30s. So there's a great need for improvement in this arena. So adjuvant chemotherapy, we've been giving it for a long time, and here's the evidence around it. We know there's a number of studies looking at stage 1B upwards, so larger tumors and node positive cancers, mainly looking at platinum doublets, and majority of them use vinorelbine, significant number use etoposide, and there is also carbotaxol in there. Varying degrees of benefit was shown in these studies, but really when we get to the meta-analysis, that's really ebbed us all towards giving adjuvant chemotherapy in definitely in node positive tumors, but also in larger tumors, any tumor that was over 4 centimeters. So the case for adjuvant chemotherapy is really very well established. What about preoperative chemotherapy? This was a systematic review and a meta-analysis of individual data, so published in Lancet in 2014, so fairly long time ago, which really showed that adjuvant chemotherapy was equivalent to neoadjuvant in terms of 5-year survival rates. So this looked at 15 randomized control studies of quite a lot of patients, over 2,000 patients, and really showed that actually you were getting 5% improvement in overall survival at 5 years, and this is almost identical to your adjuvant data that we've seen, and the benefit that you can receive with adjuvant chemotherapy. Oh, sorry. Now on to addressing the first question, then we've shown that neoadjuvant treatment is same as adjuvant. And then we go on to the next question then, is it really safe to give preoperative chemoimmunotherapy? And these are all phase 2 studies which were conducted in this arena. So larger tumors and also node positive tumors were given preoperative chemoimmunotherapy. Some of them were given CTLA-4 antibody together with immune checkpoint blockade combination, and most of the endpoints were looking at safety and feasibility. Just draw your attention to MPR, and that's major pathological response, and we'll discuss this a little bit later, but this means that we don't see that many people getting complete responses. So having an endpoint where you're not going to get that many people achieving complete response is probably a little bit foolish. So major pathological responses was thought to be another endpoint that we could use. And this is when you've got less than 10% of viable tumor left at surgery. So these phase 2 studies really very much showed that it was feasible, deliverable, and safe, most importantly. So we've answered our next question. Yes, immune checkpoint inhibitor blockade is safe preoperatively. What about, can neoadjuvant checkpoint inhibitor blockade give longer term immunogenicity? Now, the question's fairly out there still. So this is a beautiful study published a couple of years ago, looking at giving neoadjuvant nivolumab to resectable lung cancer patients. And not to go too detailed in all this science, because this is really a little bit above my intelligence, but really it was a beautiful study in that they took biopsies pre-nivolumab treatment and post-nivolumab treatment and analyzed whether you were getting macrophages migrating into the tumor, and perhaps you were then producing an immune response. And this was looking at what's called adaptive immune response. So are you able to induce an immune response in a tumor which may not have immune responsiveness and therefore wouldn't be suitable for immunotherapy or chemotherapy? And then the same paper looked at whether there was an expansion of the T cells, which really produced a memory immune response in tumors. And they really did show that there was an expansion of these T cells, T cell clones in these tumors when they were treated with preoperative nivolumab. So really nice study. So just to say, can giving immunotherapy preoperatively give us really long-term immunogenicity? And that's still possibly a question that's out there, but certainly the science would lead us to believe that you can produce immune responsive tumors by giving treatment preoperatively. So the next question is, does pathological complete response have any prognostic value in non-small cell lung cancer? Now, in triple negative breast cancer, we've proven that this is a surrogate marker really of survival. And can we do that in non-small cell lung cancer? So possibly. So I'll just show you a couple of papers here. So this consensus statement really was published a little while ago, back in 2014, and this was looking at neoadjuvant chemotherapy. So immunotherapy wasn't really in the mix here, but this was just looking at perioperative chemotherapy and the use of using this, what's called major pathological response. Now, just to remind you, major pathological response is when you've got less than 10% of viable tumors detectable in your resection and your lymph nodes. And this paper tested whether this strongly correlated to survival. And their consensus was, yes, we can use major pathological response rates as a surrogate marker to be able to predict prognosis of patients who were treated with chemotherapy, then surgery after that. So now let's get to the crux of it. We've got three main phase 3 studies which are ongoing, and some of us are recruiting to these studies. These are studies of neoadjuvant immunotherapy, and I'll just take a little while just to go through these in a little bit more detail. We'll go through checkpoint 816 in a minute, but IMpower 030 is very standard platinum doublet chemotherapy together with atezolizumab. And again, it's looking in the same population, large tumors, no positive tumors, all given preoperative regime of platinum doublet and atezolizumab. There's a little the adjuvant bit, so those patients who are randomized to atezolizumab will also receive adjuvant immunotherapy for a year after surgery. And then we have Keynote 671, which is looking in the same space, identical study looking at pembrolizumab with chemotherapy. And again, this has an adjuvant pembrolizumab arm as well, looking at the same larger tumors, node positive. So the most advanced of these studies is Checkmate 816. And I'll just show you the design of this. So again, this is a phase 3 randomized study looking at that same space, so larger tumors with or with nodal involvement, and they can't have any oncogenic drivers, so all wild type come in. performance data is again 0 to 1, and there's 3 arms. It's slightly more complicated than the other 2 studies, and this is looking at combination of your Nivo IPI, which we've all seen come into this arena. Either one of the randomization arms is your platinum doublet, your standard cisplatin doublet, or there is your platinum doublet with nivolumab. And then go to your surgery, and then after that, you can use your standard of care in trying to adjust who you would give adjuvant treatment to or radiotherapy. So the primary endpoints are pathological complete response, and we've just touched upon that. This study looking at pathology, that was the premise of this study. Event-free survival, and then secondary endpoints are overall survival and major pathological. Just going to move on. Here we are. So this hasn't reported formally yet, but there was a press release from BMS saying that primary endpoints of pathological complete response has been achieved. So we all look forward to that with bated breath. Achieve that. Slides not moving. Here we are. Okay, so this is a little resume of adjuvant studies looking at immune checkpoint inhibitor blockade in non-small cell lung cancer. So basically those patients you would consider adjuvant treatment in. And so again, it's in the same larger tumors, node positives, good performance status patients, and very almost identical design really in all of them. And they're all Pearls has completed accruing now, still open to following up patients, but these studies will take a long time to report. So Canopy A we've just initiated at our site, so it'll be nice to share experience to see canakinumab, which I haven't used in the past before. So yeah, exciting arena of adjuvant studies. So last slide. It's not really just in America and in France and Germany that you see complete pathological responses. I just thought I'd put this patient up for you to see, because it's really exciting. This is one of my few complete pathological responses. So this lady who's got this really huge tumor in that left upper lobe was deemed really far too large to give concurrent chemoradiotherapy. She also had N2 lymph nodes as well, and that field was really far too large. And I work with really quite amazing clinical oncologists who technically their radiotherapy is really excellent, and they're very pro concurrent chemoradiotherapy, but even they thought this was going to be a little bit much for them. So this lady went on to have chemotherapy immunotherapy combination as a inoperable advanced cancer that couldn't have concurrent. And so this was about halfway through. You can see she had a really nice response. And then a little bit later, she had complete functional response on her PET scan. And at that point, I took her back to the MDT, and we got advice from our surgical team and to see whether this would be operable. With a little bit of workup, MRIs and stuff to make sure that there wasn't tumor penetration into the spinal canal, etc. She successfully had surgery, and very pleased to say she's very, very well. She had a complete pathological response, came through surgery really well. So I'm hoping this is somebody we've hopefully given at least long-term control to, if not cure. So this is my last slide. So thank you very much.
Thank you, Samreen. Very clear, very concise. That's what we like. So a couple of questions coming through, and one of them, in fact, both revolve around the idea of major pathological response and pathological complete response. And one question, it relates to that paper in 2014, which is saying, if we think MPR, major pathological response in chemo, is relevant, can we also assume that's the case with immunotherapy? Or do we think we should be looking for a different marker? And on a similar theme, pathological complete response is great. That sounds really good. Is that going to be enough to convince you? Let's say in 6 months' time, on the basis of that press release, we get approval for immunotherapy combinations neoadjuvantly based on PCR, pathological complete response. Is that enough for your patients, or do you want some survival data?
Well, of course we want survival data, and that's going to be the holy grail. But, these studies are going to take a long time to report out. So we don't want patients missing out on really valuable treatment in the meantime. So that's the whole point of having these surrogate markers, giving us an idea of what we should be doing. We can't, in this rapidly evolving era, we can't sit on our hands and wait for survival data all the time. So, that would be ideal. That's what we all want to see. And we don't want to give these really expensive treatments unless we know that they're going to impact on overall survival. However, that may take a long time if these patients are doing well. So we've got to look at surrogate markers. And, the evidence thus far is that immunotherapy, chemotherapy combinations producing much better responses, much more durable responses than just chemotherapy alone. So my hope is that we're going to see actually more complete pathological responses. And then we can probably put the MPR business in the bin and actually look for complete pathological response, which we weren't really seeing a great proportion of with chemotherapy alone.
Thank you very much. I like the idea of MPR being in the bin. That's a great one. I've got a message from someone called Sanjay Popat. I'm not quite sure who he is. I've heard of him somewhere. His question is disease-free survival a meaningful endpoint in the IO adjuvant trials? We've obviously seen a little bit of this argument in the ADAURA data. What do you think about DFS in the adjuvant stuff?
Typical Sanjay to ask me a really difficult question.
What can you do? He's the boss.
I'm not sure, really. Looking at adjuvant studies, I want to see, as we discussed, we want to see overall survival. If we can get in this perioperative arena, and I know lung cancer has been really slow on the uptake in this. We've been doing this for years in breast cancer, looking at pathological complete responses as a surrogate marker. So I'm not with the disease-free survival side. I'm with get the surrogate marker and see what responses you're getting with your treatment and whether that will actually translate into survival. So probably not.
Thank you very much. We will leave you and your very erudite library behind you. I think it's a fake backdrop personally, but who knows? And we're going to move on. We're going to move on to our third and final talk, which is Ali Greystoke. And Ali is a senior lecturer and consultant medical oncologist in sunny Newcastle. And Ali's going to go through novel drugs and maybe touch, I hope, at the end on a very exciting new project, which he and a number of colleagues are involved with and which we should be very proud of in the UK. Ali, over to you.
Thank you very much, Tom, and thank you very much to BTOG for giving me the opportunity in this area. So I'm going to be talking about novel drugs and potentially personalized therapy, and particularly in terms of disclosures, as Tom suggested, I will be talking about the Concord study, of which I'm one of the chief investigators, and that does receive financial support and drug supply from AstraZeneca. So I'm going to touch on two different areas here. The first is looking at the role of targeted agents in the stage 3 setting, which Corinne just touched on in her talk. And then I am going to talk about the ability to give some of the new agents in combination with radiotherapy. So I think we're all aware of the new range of targets that are coming forward in terms of the oncogene-addicted lung cancer setting in the stage 4 setting. So we've moved beyond just treating EGFR mutants with TKIs, and we now have access also to ALK, ROS1, BRAF within the NHS in the first line setting, and NTRK inhibitors in the nth line setting. And we're likely to also see inhibitors coming through for RET, MET exon 14 skip lesions in next year, and potentially HER2 and EGFR exon 20 mutations coming forward after that. So increasingly being able to personalize in the stage 4 setting, but what about in stage 3 setting? And it's already been touched on that, there was a lot of buzz this year at ASCO and ESMO with a simultaneous publication at ESMO in the New England Journal of the ADAURA study. And within the time I've got, I'm not going to be able to talk about all the intricacies. And I would refer you to the recent podcast that included Professor Popat as to how we should interpret the study. But I'm going to touch on it in terms of the stage 3 setting. So these are patients who have had surgery. They had to be 1B to 3A, and they had to have one of the common sensitizing EGFR mutations. They had to be appropriately staged. And importantly from this study, you were allowed to give adjuvant chemotherapy. And what we found in the stage 2-3 setting, 76% of patients did receive adjuvant chemotherapy. So these patients were treated as per our present standard of care. And then they were randomized 1-to-1 to receive either osimertinib or placebo, with the osimertinib given for up to 3 years. And as has been touched on, the primary endpoint was disease-free setting and not survival, which does give us a potential early output, but as you'll see, it gives some uncertainty as to when we should use this. So you'll be aware that this was a positive study. The primary endpoint was looking in the stage 2-3A setting. And in that setting, the hazard ratio was 0.17. And if you look in the paper, you can actually see the split in the stage 3A patients. And the hazard ratio there was 0.12 for disease-free survival, with an increase in 2-year survival from, 2-year disease-free survival from 32 to 88%. So really positive in terms of that potential outcome. And we've seen some other outcomes presented, including disease-free survival. Including pattern of metastasis and reduction in CNS metastasis as a potential pre-specified endpoint. What is very immature at the present is this overall survival, which I think we would all like to see. So there's only been 29 deaths within the study, which is great. It shows a good prognosis for these patients with EGFR mutant lung cancer. With 20 of the deaths being in the placebo arm and only 9 in the osimertinib arm. So it is looking like that might be positive, but it's so immature, it's very difficult to comment on. The other thing I would like to comment on is if you look at the disease-free survival in the stage 2-3A, a large number of these patients are relapsing and doing worse than, for example, in PORT. And this is in keeping with previous data showing that EGFR mutant patients do worse from surgery alone. But, I think it is important to consider overall survival. This is a different study, the adjuvant study that was conducted in China a few years ago and presented the progression-free survival at ASCO, I think it was a couple of years ago, which showed an improvement in progression-free survival. This was a different study design. You either got adjuvant chemotherapy or your EGFR inhibitor, which was first-generation gefitinib. And whilst we saw this improvement in disease-free survival, this did not translate to an improvement in overall survival. So that's just a caution to bear in mind when we look at this setting. So what about EGFR in the unresectable setting, the chemoradiotherapy setting that Karina was talking about earlier? And I'm afraid I should have updated this slide to her most recent analysis, but there were 43 patients with EGFR mutant lung cancer in Pacific. And you will see that in terms of progression-free survival, actually, they seem to have very similar hazard ratio to those patients that were EGFR wild type or unknown. And whilst the overall survival was not presented in that analysis, I did notice it had been presented in Karina's latest update at ESMO with a hazard ratio of 1, but huge wide confidence intervals, as you'd expect. So no evidence to suggest that they might not derive extra benefit from durvalumab, but very small numbers in Pacific in patients treated with chemoradiotherapy. So what about osimertinib in this setting? Well, the LAURA study is ongoing, nearing completion, and that's taking the Pacific population mostly, in that it's patients who are receiving chemoradiotherapy but can be sequential, stage 3, fit, common EGFR mutations, randomizing 2-to-1 osimertinib against placebo. And very controversially, for me at least, that's until progression. So some of these patients who are potentially cured may stay on osimertinib until the end of their life. And again, maybe not the best endpoint from our point of view, progression-free survival. It does have some very interesting secondary endpoints, including using cfDNA to determine progression-free survival and patient-reported outcomes, which I think are very key in this setting. And lastly, coming forward, well, what about the neoadjuvant setting where we have the NeoDora study, which is looking at giving the potential role of osimertinib upfront before surgery. So these are patients who are potentially resectable and will get randomized to either osimertinib itself or potentially chemotherapy with or without osimertinib, and that randomization will be blinded. But again, we're looking at this slightly unusual endpoint that we don't know what it really means in this setting, particularly using a TKI of major pathological response. But again, some important key secondary endpoints, including failure to perform surgery. So is this feasible, and patient-reported outcomes. So lots of questions there that we're going to come on to, in terms of how long you should treat for, what's the optimum endpoint in these studies, how long should you treat patients for? I think those all came up in Corinne's talk as well. So I'm going to move on. So there is going to be one polling question here, which is, given the update, the ADAURA data that we've now seen, some of these studies coming forward, there are also studies coming forward in the ALK fusion space, which I did not have time to talk about. Do you think we should all be molecularly profiling all our lung cancer patients, regardless of their stage? So stage 1 to stage 4. So please do vote now, and I'm going to carry on and talk about the second bit, and Tom will come back to the results. So the second bit of my talk is going to be talking about giving new drugs with radiotherapy. And so what are we trying to achieve by doing this? Well, Corinne talked about the fact that we're trying to kill cancer cells, but that that side effects, toxicity is very important, and particularly when we're thinking about the heart and lung in terms of the curative setting and the potential to do long-term harm to our patients. So with a new drug, can we shift the therapeutic index? Can we either enhance the DNA damage to the tumor, or can we protect normal tissues? And particularly today, I'm going to talk about enhancing tumor DNA damage. Also, there is this so-called abscopal effect of radiotherapy on the immune system. I'm not going to really touch on that because I think that's been covered in previous talks, particularly by Corinne. So I'm going to talk to you about the Concord study, and particularly a DNA damage response. So we know that radiotherapy causes DNA damage, that cancer cells often have abnormal components of the DNA damage response, but that there are a number of agents that are coming out that can potentially target these. And these have been evaluated both as single agents in key populations, for example, the PARP inhibitors in BRCA patients, coming forward the ATR inhibitors in ATM mutant patients, but also in combination with chemotherapy. And in a test tube, you see really quite remarkable synergy with radiotherapy. So can we give these safely to patients, or are they also going to exacerbate normal tissue toxicity? So that's where the Concord study comes in. So this is a platform study where we're going to look at 5 different DNA damage response inhibitors, the safety of giving them in combination with radical dose radiotherapy, like Corinne has previously described. And as Tom mentioned, this has been a huge UK effort over the last 3 to 4 years. You can see all the partners who've been involved. Many of the people listening in will have been involved and fed back on the study design, which we think is very novel. And so this will be taking your patients going forward who are having 60 gray and 30 fractions without chemotherapy, because you get, unfortunately, you do get overlapping toxicity between chemotherapy and DDR inhibitors, particularly when you add them in radiotherapy. So we presently don't think it's feasible to give all 3 drugs together. And then patients will be allocated within a study to an arm. And within the arm, they will get randomized in a 3-to-1 basis to either the radiotherapy alone or radiotherapy plus a new drug. And you can see that the first 2 drugs coming through are the PARP inhibitor, olaparib, and an ATM inhibitor. You're saying, well, why do we need to give radiotherapy alone? Well, the answer is, whilst we've got very good clinical trial data on patients receiving concurrent chemoradiotherapy and the toxicity they experience, we don't have great data using radiotherapy alone in the updated era using things like IMRT that Corinne was talking about before. So we need a really good feel as to what the toxicity rates are with radiotherapy alone, and whether these new drugs are leading to increasing toxicity. And our primary endpoint is safety, but we've got a key number of other endpoints, and particularly, again, patient-reported outcomes, which we think are key in this potentially curative setting. And lastly, we're going to have 200 patients involved. This giving 5 novel drugs with radiotherapy. This is a key opportunity for us to do some really exciting translational science. and help us answer some key questions that we feel. So, can we predict patients who are going to develop subsequent toxicity down the line? Can we pick up in the first week of treatment patients who may run into problems towards the end of treatment or even 1 or 2 years down the line? So we're going to be doing serial biomarkers of lung and heart toxicity. Importantly, given the previous talks, what's the impact of giving these new drugs with radiotherapy on the immune system? We will be looking in adding in checkpoint inhibitors such as durvalumab to the platform as we go along. And lastly, we've got 5 different drugs. Are there some patients that may benefit from more than one drug or another? So is there something about the tumor's genetic makeup that can help us predict which patient should receive which drug? So that's a whistle-stop tour of Concord, just to say we have all the approvals in place, MHRA ethics. We're just in the final throes of setup and hoping to put the first patient on in the next month or so. And there will be, starting off with 9 centres throughout the UK, going up to hopefully 13 centres recruiting over the next 5 years. Really exciting study, and I'm really proud to be involved in it. So I hope I've shown you that we've got novel approaches undergoing away in the curative setting, both targeted treatments from the stage 4 setting moving into the stage 3, but also the possibility of using some drugs in combination with radiotherapy to both improve local control and hopefully survival. They are challenging studies in how we design and what the endpoint should be and how we get recruit patients to these studies, but I think they're well worth it because they can lead to improvements in long-term outcomes. And so lastly, my last polling question is, given all you've heard over the last hour, as I start my discussion with Tom, what do you think the primary endpoints for these stage 3 studies should be? Should it be progression-free survival, overall survival, disease-free survival, response? And I'm afraid I didn't include major pathological response. Maybe I should have included complete pathological response as an option. And with that, I'd like to thank you for your attention.
Thank you, Ali. I'm just going to give a couple of minutes or so just for those results to come through. We've actually had 2 or 3 questions asking the same thing, which is, should EGFR mutation patients in the Pacific setting get durvalumab? You touched upon that a little bit, and we recognise the patient groups that are in there. And a couple of people have mentioned the toxicity they've noticed with IO switching to OSI in patients that progress. What would you do if funding wasn't an issue?
Yeah, I think that's very difficult. The progression-free survival suggests a potential improvements, although with big confidence intervals, no difference. I think what does worry me is the potential toxicity of giving osimertinib after durvalumab and the potential risk of osimertinib. So I have used it in the EGFR mutant setting, but I think it is far more of a discussion about the potential benefits. And I'm probably leaning slightly away from giving it in that setting. But you do wonder whether durvalumab should have been included in LAURA because it is considered part of the present standard of care, or maybe it should have been investigator's choice and we could have done a subgroup analysis thereafter. I think it's an interesting question. I don't think we know.
Thank you very much. Just going to go a little bit onto the poll. So the first poll question you asked was, do we think we should be doing molecular profiling for all our non-small cell patients, regardless of stage? Every single person thinks we should. That's pretty good, isn't it? 100%. And I agree with that. Ali, are you like that? Do you get any pushback with your in your trust? Do you have to argue to get molecular profiling done unless they're stage 4? Or can you sneak under the radar?
Yeah, no. So we're moving towards stage 3 getting done. But at the moment, I would say stage 1 and stage 2 do not routinely get done.
Thank you. And then your last question, which is what do we think should be the primary endpoint of stage 3 studies? Hopefully you guys can see the answer. The great majority of people feel it should be OS, with disease-free survival and progression-free survival being coming up quite short after that. We love OS. I guess the difficulty with it is it takes more time to get. Would you agree, Ali? Are you happy with OS? Is that the best one? What are the disadvantages if you're designing your own study of relying on OS as an endpoint?
Yeah, so I think it's the length of time, and you look. We go back to the first presentation of the Pacific results, and there was this discussion then about progression-free survival versus overall survival. I think when you're looking in the setting where outcomes are very poor and you're seeing a major improvement in something like progression-free survival with something like immunotherapy, that's enough to make me switch. I think it is difficult, particularly when you're looking at a Adura, where we know osimertinib is really good and can give you really good disease control for 2 to 3 years. And unfortunately, the data we have at the moment is just stopping around about the time when the patients are stopping treatment. So a lot of, we don't know if they're then going to progress or if we're genuinely curing more patients. The melanoma setting where they use adjuvant TKIs would suggest that actually we might be, and I did show that these patients are at very high risk for relapse. So I think I haven't really answered the question. I think overall survival is too long for me, but I think we do need to take disease-free survival with a big pinch of salt, particularly when you're using a very active treatment like osimertinib that can give you prolonged disease control by itself.
Thank you very much. And just the last one or two things, because we're just 1 minute over time. And you've been very modest about Concord. It's been a huge effort for you and your colleagues. I think it's a fantastic study. Obviously, we appreciate you called it Concord because you're hoping you might end up in the Concord lounge of Heathrow, but that just hasn't worked out with COVID, how you must suffer. A couple of questions, some very nice comments saying what an eloquent study it is, beautiful study. More than one person asking which centres will be open and when might they be open. So that's exciting. Can you enlighten people, practically speaking, when they might be thinking to get people on the where they might be open?
So Newcastle, Manchester and UCH look to be the ones who are being quickest at setting it up. And I think we're hoping January. Okay.
And then a last teaser from that troublesome character, Professor Popat. Borderline bulky stage 3 disease. What's best? This is, I guess, for all of you three. Neoadjuvant IO and then surgery, Pacific or Concord. So I'll just repeat that because I'm asked all of it. Corinne, Samarine and Alistair. So borderline bulky stage 3 disease, what's best? Neoadjuvant IO and surgery, Pacific or Concord? And you can fight among yourselves. What do you reckon? Maybe Ali, if you go first.
Not Concord, because Concord's for patients who can't receive that concurrent setting. I would go for the Pioneer study in Manchester.
Very good, Corinne.
That's a good one, Ali. Excellent response. I think I'd like to know actually a lot more about this tumor. There's all sorts of aspects that we know we could take into account in terms of making a more personalized decision. Is it a tumor that is, very hypoxic, on CT or PET CT? Do we have the impression there's areas of hypoxia, which then, would make us more convinced that surgery is the right thing to do as opposed to radiotherapy? We look at ctDNA, there's all sorts of things like that. I think in the future we need to look at to personalize our treatments more. Anyway, I'm not answering the question. Not really.
And Sabrina?
So as we're so poor in the UK for giving concurrent chemoradiotherapy, I think we ought to advocate that far more than any other treatment, since it's shown the best overall survival so far with anything that we've done. So, I would push the concurrent chemo radiotherapy bandwagon much more. And if it's truly, truly unencompassable, and by an experienced clinical oncologist who said it's not doable, then you should go for preoperative, pre-treatment chemo IO and see how you go. But keep it personalized. So evaluate your patient. Don't just assume this is advanced disease and never locally treatable. So please keep doing your evaluations. Make sure you're seeing the performance status of the patient. Make sure they're not declining as you're giving them immunotherapy, because it does come on a little bandwagon. So if you're getting a response, represent them to your clinical oncologist colleague to make sure they're not able to consolidate radiotherapy, and then maybe take it back to the MDT for surgical resection, because we're on a completely different path now. So we need to keep challenging our MDTs.
Thank you very much. I think that brings us to a close. Thank you to my three excellent panelists. Thank you to Gina and Dawn for coordinating all of BTOG's activities, and of course to our sponsor Amgen, and also to our working behind the scenes, Richard from First Sight Media, who is coordinating all of this. Look after the website for more exciting webinars to come along. The next one is in January the 18th in 2021, and that's going to be on molecular subtypes, beyond EGFR, ALK and ROS, so really the kind of cutting edge of the new stuff. So we very much look forward to seeing you there, hopefully with some of us having had some vaccines between now and then. So I'll call it to a close, and we wish you a happy Christmas and a nice new year as well. Let's hope it's better than 2020. Bye-bye.
Bye-bye.